Three big objectives here. First of all, just to understand the rationale for why ICH should be a code, and then discuss the research support, and then we'll also talk about new stroke center system approaches kind of throughout the whole presentation. So, this is a huge emergency. It accounts for a small number of strokes, but when you look at the strokes that do come out with ICH, these patients are the ones that are likely to die. In fact, when you're looking at statistics from an administrative standpoint, and you see high death rates, and you really drill into that, it's generally your ICH patients, followed by the SAH patients that are pushing your death certificates and your high lengths of stay and all the morbidity. If you survive the ICH, you are likely to be significantly impaired. And when we think about everything that's happened from 1990 to present day, most of what's happened to support care for stroke patients has been in the realm of ischemic stroke management, not really ICH. However, worldwide, again, this is the most deadly form of stroke that you can have. Now, the big thing to keep in mind is that hematoma expansion is largely the biggest driver for why these patients don't do well. And it's a front-loaded emergency. These patients generally in the first 2 to 3 hours are going to expand the size of that hematoma. So, and it's interesting because I've had emergency nurses come up to me and go, well, he didn't look so bad when he was in the ED. How come he looks horrible today? And you look at the size of the bleed, well, maybe it was like this when he came into the ED, but now within a short period of time, that hematoma has enlarged pretty significantly. And even a tiny amount of blood, if it's in the wrong place in the brain, is likely to make a significant difference in outcome. And we know that about 20 to 40% will grow that hematoma more than 33% in size, like what you're seeing here. And this is significantly associated with just patients doing terribly. So anything that we can do to try and reduce the risk of hematoma expansion is huge. There's lots of reasons why these patients don't do well. And it starts here, and that is that, if you think about most of the hospitals in our country, and probably most of the hospitals in Idaho, are not really equipped to manage these patients, right? They don't have the specialists to manage these patients, like a big comprehensive stroke center has. And the other thing is that oftentimes there's incomplete imaging, and think about this yourself if you're someone that works in the emergency department. If you see blood on a CT, do you continue on to a CTA? And most people would say no, we just stop the protocol right there, whereas what the Code ICH Task Force is saying is no, do the CTA for several reasons, because it can give us information about whether it's a structural hemorrhage, if it's in kind of a funny looking place that's not typical for hypertensive hemorrhages, for example. And the other thing it can do is tell us about patients that are actively expanding the hematoma, as I'll get into in a minute. But we also have problems with long dido times, or door in, door out. And it's really multifactorial. It's not necessarily just the small hospital's problem. Indeed, oftentimes we find in smaller hospitals that they're a little bit slower in moving the patient through the process. And usually that's due to less resources being available. You might have one emergency department physician for a department that's now loaded with patients that are actively infarcting, a patient with a car accident, for example, and other things. And so they get distracted. They don't have time to do it all. But transport is the biggest problem. Transport by far is the biggest reason why dido times are long. And then sometimes it's our fault at the big comprehensive stroke centers because we don't have good throughput and acceptance. Like we might not have enough beds, and so we tell you to sit and wait. And those things are not good either. So really, we need to find ways that we're more aggressive with these patients. But sadly, even at comprehensive stroke centers, when a patient comes in, oftentimes if there's blood on a CT scan, the entire stroke team goes, okay, we're out of here, there's nothing we can do. And that's wrong. That's really, really wrong. In fact, I won't disclose who, but recently I was speaking at the Sun Valley Cerebrovascular Conference, and someone from a very big name institution said that is exactly what happens at our place. If there's blood on the CT, the entire stroke team leaves, and we wait until someone else like neurosurgery or neurocritical care can come down and manage the patient. Well, if neurocritical care is dealing with an emergency in the ICU, that could be an hour later. You never know. And so this is really suboptimal management. What she was telling me is that none of them really know how to do hemorrhagic stroke, and so they've just chosen not to do it at all on their stroke team. And so this is just a huge issue, because really, if you're a vascular neurologist, you have to know both hemorrhagic and ischemic stroke. And then lastly, unlike ischemic stroke, where we've got all these quality metrics that Joint Commission, American Heart, DNV, other accrediting agencies have gotten behind. In hemorrhage, there's like a handful of things, and it's by no means the way that it should be. So what we're going to do is look through this list real quickly, and there's a lot of stuff on here. But the first thing that we're going to look at is non-contrast CT, immediately followed by a CTA, because that's going to help us with risk of hematoma expansion and being able to evaluate that. And this is patient's non-con CT. You can see that there's kind of a bright white dot in there. It's kind of hard with the lights on in here to see imaging real well, but if we turn them down, y'all will fall asleep. So, but it's kind of right there. Does everyone see it right up at the top, that kind of bright white dot? If you did a CTA, you can see that same spot of hemorrhage, but see that one bright dot in the middle of it? That's showing you that there's active bleeding inside the hematoma. And again, I could have seen that just on the non-con if I really blew it up and carefully looked at it, that there's that brighter white dot here. But here's the patient 6 hours later on their stability scan, and you can see that that hemorrhage has really just about doubled in size. And so this can be very, very helpful to us. And again, if it's a bleed that's in an unusual place, and there's fairly standard places for hypertensive bleeds, which is the most common form of ICH, and those are generally the basal ganglia as number one, followed by the thalamus, followed by the pons, and then occasionally we get them in the cerebellum as well. But if it's not in those places, then we generally need to think about, could this be a structural hemorrhage, like an aneurysm, which you're gonna find at places where vessels bifurcate usually, right? So at the bifurcation of the A1 to the A2 and the ACOM-A, right? And that's your most common one, or at the bifurcation of the MCA. And so those are kind of easy even without the CTA. We'd still do the CTA, of course. But the AVMs are the ones that show up in really bizarre places. And so that's why it's helpful at times to really do this. Now, the next thing we'll look at briefly is artificial intelligence. How many are using artificial intelligence supported imaging? And by this I mean like VizAI or Rapid. So I know you guys have it here. What about the smaller hospitals?
West Valley does.
Okay, good. Any other small hospitals here have it? If you don't get it, do get it, because it's fantastic. What happens is you get someone like Ray, who is just doing rounds here, and all of a sudden his phone will bleep, and he'll look at it, and he can see that all the way up at Wood River Valley, there's a big hemorrhage on a CT scan before anyone from Wood River Valley even called him. And that's incredibly helpful, because now he can begin looking at how can I get this patient here quickly, because he's got resources here that they probably don't have there, right? And it's going to take them a longer time. So he can start mobilizing aircraft to get up there, getting the team organized here, making sure there's a bed ready and such. So these AI programs like Rabbit and Viz, and there's others, AI Doc is another one, they're all wonderful, because they allow us to kind of see in real time where these patients are. And And then comprehensive stroke centers, having it here is great because it allows us to really increase the internal communication because it comes into our phones again. And everyone throughout the entire hospital is able to see exactly what's coming in that they need to now manage. The next one is admission NIH stroke scale scores, Glasgow coma scales, and ICH. How many of you are doing an NIH stroke scale score on a patient with an ICH? Anybody? A few people, good, excellent, you should be doing that. You know, the NIH is now considered a valid tool to use in ICH. It used to be that we only said use the GCS. And actually one of my doctoral students that has since graduated, Dr. Wendy Dusenberry, as one of her 4-paper dissertation, actually did a study validating use of the NIH and ICH patients. I'll talk a little bit more about that later. But it is something that you should consider because it gives you a good disability assessment. Whereas the GCS, there's lots of limitations to. One being that it tells you to take the best response. And we don't want the best response because we're trying to find out what is focally wrong with patients. But we do still use the GCS because we're gonna trichotomize it as part of the ICH score, which I'll talk about in a minute, and dichotomize it for the thumb. We also do, in the ICH score, volumetric sizes of these hemorrhages. And generally that's been done by the A times B times C divided by 2 methodology, which is consistent with Cartesian mathematics, if you have an ellipsoid or sphere-shaped bleed. Now though, in these new AI programs like Viz and Rapid, they will automatically tell you the size of the hemorrhage. So you don't even have to do math anymore, which is always a good thing. It is only valid if you're doing the Cartesian mathematics and ellipsoid-shaped hemorrhages. You're just multiplying them together and then dividing by 2. And according to mathematicians, this is still consistent with how you do it regardless of whether you're doing 1 millimeter or 5 millimeter slices on the CT scan. So just to kind of give you a feel for this, you're taking these cross-sectional right-angled measurements for A and B, and then you're counting the number of slices that you see the blood on, and you're multiplying all of that together and dividing by 2. So this is a fairly accurate measure. On something like this, though, this is not going to be accurate because it's not an ellipsoid or sphere-shaped hemorrhage. But it's been the best that we've had for many years. And you just knew that it wasn't accurate. It was probably overcalling potentially, but you went with it. If you are still doing that, you don't count the slices where you see blood in the ventricles. Just keep that in mind. Here's the ICH score then. We're using the trichotomized GCS scores. The ICH volume, whether it's greater than or equal to 30 or less than 30. Do they have intraventricular hemorrhage, yes or no? Is it infratentorial, like a pontine hemorrhage, for example? And then their age, are they greater than or equal to 80? And you're assigning points. And the more points you get on the ICH score, the greater your risk for 30-day mortality. And you can see that once you're up to a 5, 100% of these patients were dead. The unfortunate thing about ICH is when we see these big bleeds, we oftentimes just go, okay, we're not gonna do anything because this guy's too far gone. And a lot of very aggressive neurocritical care docs have argued, give them a trial of life over a couple of days and let's see how they do. And if they do okay, then, you know, so be it. If they don't, now we'll start pulling things. And you get into this kind of tug of war between ethicists and clinicians about what's the right thing to do for patients, and once you've intubated, can you extubate, and all this kind of stuff. And it is still a bit of a diagnostic challenge, if you will, and prognostic challenge as to what we should do to manage them. But that's your ICH score, and generally this is supposed, we used to say it was done on admission. Now we say do it at the 6-hour stability scan, which I'll talk about later. The funk score is something that Natalia Rost up at Harvard actually created, and it's looking at functional outcome in patients with ICH. And it's exactly the opposite of the ICH score, because the higher the score, the more functionally independent you are in these patients. And again, it's pretty much the same thing, looking at volume and age, location. The GCS here is dichotomized, and then do they have premorbid cognitive function? And the higher the score, the better the patient does here. So they're kind of exactly the opposite. Blood pressure lowering generally is recommended to be started within 30 minutes from arrival, and it should be done using a continuous infusion agent. For example, clobidipine or nicardipine. Your dihydropyridine calcium channel blockers are really your best bet, because you turn them on and they work, you turn them off and they stop working. So they're really, really nice agents to use. The thing to kind of keep in mind about blood pressure lowering is that this recommendation is derived strictly from secondary analyses, which I really find interesting, because American Heart kind of prides itself on recommendations that are fully evidence-based, and secondary analyses generally are not considered to be fully evidence-based because they're an exploration that is more hypothesis generating than it is hypothesis testing. It was first demonstrated that you certainly could do this in a very feasible manner in the emergency department. And one of the things that we learned from the ATTACH-2 trial that was done by Adnan Qureshi is that if you did this in an ultra early fashion, within the first 2 hours of the bleed, that it seemed to reduce hematoma expansion. Overall, ATTACH-2 and INTERACT-2 trials were negative. So this is again from the secondary analyses. They did find in ATTACH-2 that Asian race seemed to be associated with lower risk of expansion. And when they pooled INTERACT-2 and ATTACH-2, they found that you could get it down to as low as 120 over 130, and that was associated with fairly reasonable outcomes if the patient had a mild or moderate ICH. But when you drop the blood pressure more than 60 millimeters of mercury, it became dangerous. And if you look at INTERACT-3, these are all Craig Anderson's trials, and of course he makes me nuts, but INTERACT-3, he likes to pound on his chest and say, we found a treatment. It was a bundled care treatment for ICH, but if you actually read the trial, it really was a blood pressure lowering trial more than anything, because most patients didn't get the bundle, which is interesting. And it was a huge trial, thousands and thousands of patients. And if you look at the actual difference in blood pressure between groups, it was only 6 millimeters of mercury on the systolic. Now, I don't know about you, but I would argue that the larger the trial, and we know this is true, the greater the likelihood you can find a needle in a haystack with a very low effect size, meaning that you'd have to enroll another several thousand patients to have one patient benefit, right? And so it really, I don't find this trial to be very helpful. If you look at it at 24 hours, the difference between groups was only 3 millimeters of mercury. And so there's been a lot of criticism of yet another Craig Anderson trial, mainly because of large enrollments, poor design, and he also didn't enroll a lot of patients with very high blood pressures. And so these patients came in with relatively low blood pressures to begin with. When I look at this in comparison to Memphis, Tennessee, our patients come in 260 over 140, right? He didn't have anyone like that in his trial. He had patients coming in 170 to 180, around like that. Some of them came in 160. So that's not really generalizable to me, and it would be dangerous for me to think that I could get blood pressure down from a 240 or 260 over 140 to a systolic of 140. I'd be causing a lot of end organ damage. The other thing that really challenges a lot of what we know about blood pressure is that when you look at these trials, they use different devices for all the measures of blood pressure. Some were using a finger plethysmography, others were using cuffs here, others were using cuffs here, and there's no agreement between these devices. There's a lot of research that shows that they are not equivalent. They do not agree with an art line. They don't even agree with a manual cuff pressure. And so it causes you to say how much error is in these studies. And I think there's a ton of measurement error in them. And really we need better designed studies overall for blood pressure. Reversal is another issue that we need to talk about because there's agents that demand that we use certain types of reversal agents. And when we think about what these are, you're talking about warfarin reversal, you're talking about dabigatran, which is a direct thrombin inhibitor, and you're talking about apixaban and rivaroxaban, which are factor 10A inhibitors, right? And these drugs all need to be reversed with very specific agents. So you can't say, I'm only gonna stock Praxbine, or I'm only gonna stock 4-factor PCC, because those drugs are not gonna work unless it's on the specific agent that they're meant to work for. So we know that, for example, if it's a warfarin bleed, which we're seeing less and less of, and generally when we do see them, it's because it's a cardiac patient with a valve that's on warfarin. We need we need vitamin K and 4-factor PCC, for example. But that's not gonna reverse a factor 10A inhibitor. And so you've gotta really, dig deep into your pharmacy and make sure you've got the right drugs to reverse whatever agent. The next one is neurosurgery consultation for hematoma evacuation within 45 minutes of arrival. And a lot of this is work that just continues to evolve over time. There's been numerous clinical trials that have been negative, including STITCH and STITCH 2, MISTY 3, and then all of a sudden there was ENRICH. And ENRICH was positive, but it was positive because they used an adaptive design that allowed them to kick out a lot of basal ganglia hemorrhages and to stop enrolling them. So really, when you think about ENRICH, what made it positive was the fact that they started doing more cortical hemorrhages, and so the trial did great. There is a lot of work that still needs to continue to happen to really allow us to understand what to do for these deep basal ganglia hemorrhages. They're hugely difficult to manage. These are the ones that really tend to expand a tremendous amount, and so we need to do a better job with that. The next one is the NIH for serial assessment. Now, as I said, we've traditionally used the GCS, but there's all these limitations, especially the fact that you're supposed to be picking the best response. The NIH is actually going to capture the disability. You look here, here's an example of the GCS and how poorly it responds. If the GCS is 13, 40% of the time, if the NIH was 13, 40% of the time the GCS said the patient was normal. An NIH is 13 is pretty bad, right? And so you can see that you're really not capturing it with that. So in Wendy's work, this is an example of what her sample looked like, but she had 672 ICH patients. You can see the mean age was about 62. Most of these were basal ganglia hemorrhages, and 45% had intraventricular extension. Now, what you're going to be looking at are receiver operator curves or ROC curves, and these are going to plot pairs of true positives versus false positive rates. And it gives you an ability to really kind of look at how well different instruments perform. So what you're hoping to do is see that the top left-hand corner of the graph, whatever reaches out to the top left-hand corner, is the better performing instrument. So for example, looking at the NIH stroke scale, it discriminated better than the GCS for large hemorrhage volume, but it's not a massive difference. It is statistically significant, but it's the blue line. It's not a massive difference. But look at this one. The admission NIH discriminated significantly better than the GCS for looking at poor functional outcome at discharge. And again, this is a pretty dramatic change over here. You can just see how we're just reaching out towards that upper left-hand corner here. And so this is a great thing to use. The other thing that we found, we had a median discharge modified Rankin of 4. 67.5% had bad modified Rankins of 3 to 6. You can see the death rate and the discharge home rate. But with each point increase on the NIH, the odds of a discharge with a modified Rankin 3 to 6 increased by a factor of 1.28, which is phenomenal. So you can literally add up your odds of going home pretty disabled or discharging dead. With each point increase, you also had the odds of being able to independently walk changed by a factor of 1.61. And that's pretty sad, right? So this is a great tool for us to be looking at our patients with. Next, head to bed up 30 degrees, and Ray made it easy for me because I don't have to really dig deep into head coast, because he already explained why head coast was a bit of a flawed clinical trial. Chris Diner, after it was presented at the International Stroke Conference, was interviewed by Neurology Today and said head coast was the most flawed clinical trial that has ever been presented at the International Stroke Conference, which is kind of a wow statement to see that. So there are a lot of problems with this trial. And as Ray had said, they did enroll patients with ICH, and they tried to say it was okay for you to lay an ICH patient flat. And these are all the problems with it, so I'm going to skip that slide. But one thing that Craig Anderson did before this trial was do a big international survey looking at what people thought about head position. He only really asked about ischemic stroke patients in head position. So we decided, and Wendy Dusenberry did this study with me as well when she was doing her PhD, we decided we would do an international survey and ask people whether they believed that head post gave definitive recommendations on how you can safely position an ICH patient. And so you can see the sample here was mainly North America. We had a nice mix of registered nurses, advanced practice providers, and physicians. And these were experienced people with about 8.6 years experience and a median a median of 100 patients each year at their hospital. But you can see the results of our survey pretty much showed that people did not think that head post provided definitive guidance on how to position an ICH patient. And in fact, most hospitals had protocols saying sit them up 30 degrees. And really it was not adequately explored. So Wendy, one of her goals, which I keep telling her, get me that protocol, now that she's graduated with her PhD, wants to study what happens in a clinical trial when you do a repeated measures design of 30, 15, and 0 degrees in ICH patients with multimodal monitoring repeated constantly to see how these patients did with ICP, for example, clinical change, etc. So hopefully we'll be getting that started at some point soon. Aggressive ICP treatment does remain the mainstay of how these patients with high intracranial pressure are managed. We do know that secondary injury it is absolutely devastating, and it's largely inflammatory. And I think that Dr. Pearl did a really nice overview of that, so I'm gonna skip through that. There's lots of experimental agents that have been tested to look at edema management. Right now, we don't have a silver bullet here, but we know that ventriculostomy, bolus osmotherapy, short-term hyperventilation, not long-term, because you're gonna shift the patient on the oxyhemoglobin dissociation curve to the point where they're gonna create more tissue ischemia, and then surgical decompression can be very important. The repeat imaging and continuous EEG are very important. You know, these patients fluctuate pretty dramatically as the hematoma gets big. And, you know, the other thing is these patients are at significant risk of seizures. And, you know, I can't help but think back to all the years that I've been doing this, and we would have these patients that looked worse than the CT scan. And we'd say, why do they look so bad? The CT doesn't look bad at all.